It's our pleasure today to run this nice webinar with two of the eminent in the field of sports injury from two different schools, the French European School, Dr. Philippe Landreau, and the North American School, Professor Brian Cool. So we will start first with Dr. Philippe Landreau. He will give us a presentation about how he's doing meniscus repair, what is the indication, technique, and everything. Dr. Philippe Landreau is currently the Chief of Surgery, Chief Medical Officer at DX Bone and Joint Excellence Center in Dubai. Our second speaker is from the North American School of Sports Medicine, is the well-known Dr. Brian Cool. So Dr. Brian Cool, he's actually a professor of orthopedic surgery at Rush University. Welcome, Dr. Brian.
Thank you for having me.
Thank you. Thank you very much for being with us. So we will start quickly now with Dr. Philippe Landreau with his presentation on meniscal repair. Please, Dr. Philippe.
Thank you, Usama. Thank you so much again for the invitation. It's a pleasure and an honor to be invited in this field of Emirates Orthopaedic Society. And I know that since I've been there for 1 year that this society is very dynamic. I hope you see my presentation. It's okay?
Yeah, we can see it. It's very well now. Yep.
Okay. So my task is to give an overview of the meniscus repair in 2020. I will not talk more than 30 minutes, and even if we talk about that during 30 minutes, it's difficult to go in all the details because it's a so broad and big topic. But currently, I will try to answer to some of the questions that people ask regularly, and I'm asking myself the question about these topics. Maybe not how we do the repair, even if the techniques are in full evolution, but maybe which one and when and what kind of result we can expect from this meniscus repair. So I will draw a broad vision on the meniscus repair, again, without going into detail because we don't have time, but I will focus at the end on, and I will highlight two specific fields, which are the ramp lesion and the root tears, which are maybe less known and that they were highlighted during the last decade, and I think it's an interesting topic. It's clear that even if there are still some controversies in this field, the meniscus preservation is now a goal for everyone. It's the goal because we know now that the long-term follow-up after meniscectomy shows high risk of osteoarthritis. In the same time, because the surgical techniques have clearly improved, they are easier, faster and stronger and more efficient. And maybe because we can add some adjunctive therapy to enhance the healing process of the meniscus repair. I will not go to the detail of the anatomy because everyone knows that, but I think it's important to know clearly what is the anatomy of the meniscus if we want to start to do repair, but particularly ramp, root repair. So it's important to have a good idea of the accurate anatomy of the meniscus. It's interesting to know that the meniscus are composed for 70% of water, so we repair 70% of water, but this is a general comment for the body in general. And 30% are organic matter, and within this 30%, 70% are made from different types of collagen. Everyone knows this picture of Arnowski from American Journal of Sport Medicine in 1982, showing the vasculature of the human meniscus. So to summarize, it's very important to know that there is a microvascular perimeniscal plexus, which is formed from the medial and the lateral geniculate arteries, which are branches of the popliteal arteries themselves. And it terminates in a short network of capillaries that extend from the periphery inwards It represents 10% to 30% of the width of the medial meniscus, 10% to 25% of the width of the lateral meniscus. This is very important to know that. So from now, and from when we understand this anatomy, this micro anatomy, we can easily understand that the repair of the peripheral part of the meniscus should be the most successful for vascular reasons. The menisci has a high role and in the biomechanical function of the knee, and they are in charge of knee load bearing, shock absorption, joint stability, even joint lubrication. And we know now that any disease or any deficiency of the function of one of the meniscus can have a serious effect on the biomechanical function of the knee and lead to osteoarthritis, and everyone knows that. It's quite difficult to conclude and to give a result about the meniscus repair, first of all, because we have different types of tears, and Iseko's classification solved this problem partially, because we can talk about acute and degenerative lesion. It can be lesion in the vascular and avascular part of the meniscus. There are different patterns. It can be horizontal, it can be longitudinal, vertical with a bucket handle, it can be oblique, radial or not with a flap, it can be complex. And there's even special location, and we'll go back to these two topics, roots and ramps. So it's quite complex in terms of type of tears, and all of them, they don't have the same result if we repair them. And in addition, there are the specific cases like degenerative lesions that were classified by Dorfman a long time ago already now, but we will not talk about the degenerative lesion because usually we don't repair them. It's another topic. And there is a special topic, which is the discoid meniscus. Again, I will not talk about that in my presentation, but we can still discuss during the discussion after the R2 presentation. So roughly, what are the indications currently in 2020 for a meniscus repair? First of all, it depends on the vascular supply. You know that there are three zones in the meniscus: the red zone, periphery, the red-white zone, and the white-white zone, depending on their vascularization. In the red zone and red-white zone, there is high chance of healing, and some papers show that the lesions which are 2 mm from the meniscus rim have the highest rate of healing. Conversely, in the white zone, the central part of the meniscus, there is a lower chance of healing, and if the lesion is more than 4 mm from the meniscus rim, there is a high rate of failure. So we should not repair lesion more than 4 mm from meniscus rim based on this vascularization. On the other side, we know that in young population, we need to fight and we need to try our best to repair all the meniscus. So it's not only depending on the vascularization, but the age and the different conditions. So for example, in the older patient, we will not probably repair in the white zone, but if it is a teenager, probably, and it's probably the best way to do, is to fight. This is what I'm doing in my practice, to really repair as we can repair to save the meniscus if we can, even if we know that the chance of healing are not 100%. The length of the tear can play a role can influence the repair. If they are less than 1 cm, they are stable, and usually they can often spontaneous heal, particularly in the context of ACL tear and ACL repair. If it is more than 4 or 5 cm, it's by definition unstable. There is a high rate of failure, so it means the repair must be extremely strong and correctly done. Based on the type of tears, the indication can be different. There are different, I put on this slide only few, there are others, but the main type of tear that in practice, because we must be pragmatic, are radial tears, horizontal tears, longitudinal vertical tears, and root tears. In case of radial tears, in white zone, more or less red-white or red zone. So you know if the radial tear is limited to the white zone, there's clearly, in my experience, I don't think we should repair, except maybe in very young patient, even though, because we know that the rate of the failure rate is very high. But when this lesion reach the periphery of the meniscus, particularly in the red zone or red white zone, we know that biomechanically there is a deficiency. It creates a sort of deficiency and lack of biomechanical support of this meniscus in the knee. So if we don't treat this kind of radial tear, which when they are on the periphery of the meniscus, there is a high risk of increased lesion in the future, and it can become like a total meniscectomy. And we will discuss about that. We'll come back on this topic with the root tear, where some papers show that a root tear, which is nothing else than the radial tear, can be equivalent of total meniscectomy. So a deficiency of the meniscus. So the radial tear, which were probably underestimated in the past, should be repaired if they are in reaching the periphery of the meniscus. When there is a longitudinal vertical tear, these are the frequent lesions, particularly in the context of ACL reconstruction. Clearly, we usually repair. We repair them because they remove, if we do a meniscectomy, we will remove the majority of the meniscus, which is bad, of course. And for the other reason is that usually it's placed in it's situated in the red zone or red white zone. So the chance of healing process of healing are high. So there is a reason to repair this longitudinal vertical tear, and probably these are the most frequent repair that we are doing in our practice. Horizontal tears are frequent, but often degenerative. So usually we don't repair them, except in young population, and you can still repair after debridement, stimulation, these kind of repair, like you can see on this picture. There is no evidence, and there are some controversy about that, but probably more, and again in my practice, more the patient is young, more I will try to fight to repair this meniscus, even if I know that one part only can heal. It's only always better than to do a significant meniscectomy. Finally, the root tears are equivalent, could be equivalent to a complete meniscectomy if there is unstable and complete posterior root tear. We will come back on this topic later on. There is another topic, which is the timing and the age. Normally, we should, the good sense should be to say that more we wait, less is good for the healing, and more we do the meniscus repair in the older population, less is good for the healing. Actually, there are some controversial papers, but roughly, I would say it's always better to, we can say that there is a sort of consensus that it's better to repair the meniscus tear before 3 months after the injury, particularly if we talk about ACL reconstruction in the same time. And there is an age, 40 years old, which is a sort of frontier before and after we go to a meniscus repair, but this is something that we can discuss later on. So now, what are the different technique of meniscus repair in 2020? You know that there are 3 big types of repair: inside out repair, outside in, and all inside. The inside out repair was the first one described when we started to do arthroscopy of the knee a few decades ago. This technique is still a good technique. Personally, I don't use frequently, but I know that some surgeons are using regularly. It's versatile. It allows strong repair, less intra-articular irritation, low cost, but it's the price to pay is a little bit more invasive because you have to do a medial or lateral approach. You have to protect the soft tissue with this spoon or this kind of retractor. But it's clear that this type of repair lead to good healing process, good fixation, strong fixation, and this is a very good technique for the meniscus repair. And probably some of you in the attendees are still using, using this technique with success. The outside in technique is interesting because the anterior part of the meniscus are difficult to reach or even impossible to reach when we use the inside out or all inside. So in our practice, it's important to know how to do outside in technique, either with a specific instrumentation for the company or with a simple needle with a different technique, but which are still with the same concept to pass two suture from outside to inside and to do the suture on the capsule. This is easy, this is low cost, it's safe. It's probably for me in my practice the only way to repair the anterior 2/3 or at least anterior 1/3 of the meniscus, particularly for the anterior part of the lateral meniscus. And this is something that we should have in our skill. I mean, I cannot imagine a surgeon doing only all inside procedure based on the fact that it's easy and not very complicated to do. The outside in technique for the anterior part of the meniscus should be something that any surgeon should do, and particularly for the, I believe that Brian will we talk about the transplantation. When we do a meniscus transplantation in the anterior part of the meniscus, we use this kind of technique. And then the all inside. All inside is probably the most recent kind of technique. It was a big progress in our surgical technique because, you know, it's very fast. Remember, this is an old video of a technique of small darts, you know, absorbable darts that we used in the beginning. I don't know how long time, but maybe 20 years ago. Before that, we had some arrows and darts non-absorbable. And the experience probably started during with Morgan, 1991, I believe. And then happened the new generation of all inside repair, which are less aggressive, with less complication, stronger, easier, faster. The big advantage of this all inside technique, the common advantage, is to be able to repair the posterior part of the meniscus, which are probably one of the most frequent meniscus tear. So obviously we need to have that in our weapons, I would say. Posterior part of the meniscus should be done with all inside, and the other technique should be done in addition to this technique. But they are more expensive. They are less and less invasive, probably, because now we see some old suture meniscus repair, which are probably a great evolution to avoid irritation or this kind of complication that we could see with the small implant. Anyway, the concept is always the same. All inside technique, so less risk for the vascular or for the nerve. It doesn't mean that there is no complication for this kind of implant, and we will talk about that later on. What about the result? If we, I cannot go in the detail of all the technique and so on in the 30 minutes, but roughly what are the meniscus repair outcomes? We can say that based on the literature today, the success rate of meniscus repair goes from 70% to 90%. It means the mean failure rate is around 15%, but it's an average because it depends on many things: age of the patient, type of lesion, concomitant surgery. But multiple factors influence the success. We can say that the medial meniscus has more failure than the lateral meniscus repair in general, and there is clearly a greater success in the reconstructed ACL. So it means when we do an ACL reconstruction, there is no reason to not repair the meniscus because the failure rate is very low in all the series currently. There are some complications, and I would like to highlight this because, you know, probably it's underestimated. I remember in the French Orthopaedic Society, we did a symposium with a big study about the complication after knee arthroscopy, and the meniscus repair were one chapter of this potential complication. It's rare, it's not frequent, fortunately, but it can be dramatic. the popliteal vessels are not so far from the posterior horn of the two meniscus, not only the lateral meniscus, but the medial meniscus as well. So it's important to keep that in mind. And just look at any axial view of your MRI of your patient, and look at the location of the meniscus, look at the location of your vessel, the posterior vessel, and you can imagine that if you don't have a penetration limiter in your device, which is very important, and I will advise you to use this kind of thing, not more than 10 or 15 millimeters, not 10, 15 millimeters when you are in the posterior part of the lateral meniscus. There is clearly a high risk of lesion of the vessels, particularly because it's difficult to do this repair in the flexion. You know, for example, that in the posterior cruciate ligament, there is a risk for the vessel as well. And the way to avoid and to decrease the risk is to do the procedure in a 90 degree of flexion, which push the vessel posteriorly. But when you do a meniscus repair, it's very difficult to do that in flexion. You have to do that in the extension or close to the extension. So the risk is clearly present. So always think about that when you go to the posterior part of your meniscus. But it's not only the vessels. We have the common peroneal nerve. Everyone knows that, and usually surgeons think about that. You know, it's this nerve with turning around the fibular head. It's important when you try to manage and to do the repair of the posterior part of the lateral meniscus, but not only the common peroneal nerve, the saphenous nerve on the medial part of the knee is there, and it's not rare to see some complication on the saphenous nerve, because everyone think about the peroneal nerve, but some of us, we forget sometimes the saphenous nerve on the medial part of the knee when we do a medial meniscus repair. And the lateral geniculate artery, which is not a disaster like a popliteal artery problem, but it can lead to some bleeding and hematoma after meniscus lateral meniscus repair, because this artery is closer to the lateral meniscus than the medial geniculate artery. And we know the complication based on the previous implant, the implant that we used before the low profile and the suture-based implant that we use now for all inside the system. This implant were more or less aggressive, rigid, and we have some paper in the literature showing sometime disaster on the medial or lateral condyle with some rubbing lesion, with cartilage lesion, particularly the darts, which are probably abandoned by the majority of the team now. But it can break, it can lead to loose bodies, cartilage damage, and still the new generation of all inside the procedure can make some rare but sometimes irritation on the capsule around the meniscus, and I have one or two cases in my experience like this. So after this global vision, and I'm sorry if it was a little bit overview and we didn't go to the details because we didn't have time, and I'm happy to answer to the question after the presentation. I would like to focus on two specific topics which are probably less known by the majority of orthopedic surgeons, but they should know that now because it's something clearly well identified during the last decade. First of all, the rump lesion, and then we'll talk about the root tears. The rump lesion, by definition, are a meniscosynovial or meniscocapsular lesion of the posterior medial meniscus. It was described by Strobel in 1988. And these lesions are really commonly, or even almost always, associated with the ACL deficient knee, both in acute and chronic setting, by the way. And the incidence increase with the time from injury, particularly if the lesion or the rupture of the ACL is more than 3 months after the injury, showing that these lesions are linked to the anterior translation of the tibial plateau. The incidence is quite high, and it's quite surprising. And we discovered that during the last years, between 9 to 24%, even more, until 40% for some papers. The posterior horn of the medial meniscus, and the rump lesion is medial meniscus, not lateral meniscus for anatomical reasons. So posterior horn of medial meniscus is a secondary restraint to anterior tibial translation. So we can understand that the lesion in this area can lead to an increase of anterior tibial translation, and even can contribute, as shown probably by some recent paper, to ACL graft failure if it is not treated, if we talk about a significant rump lesion. There are specific risk factors, and we need to pay attention to that. Apparently, the rump lesions are more frequent if the patient are younger than 30 years. If it is a revision LCA reconstruction, we can understand why. If it is a chronic injury, if there is a preoperative side-to-side anteroposterior laxity difference of 6 mm or more, so it means a large, important Lachman, anteroposterior laxity, and the presence of concomitant lateral meniscus tear, probably because it shows that it's a chronic and important lesion. The clinical and the MRI diagnosis can fail, and it's not so obvious to do the diagnosis. So we need a high index of suspicion, because sometimes more than 10% of the MRI can be negative, even if there is a significant, if there is a clear rump lesion. So for that reason, the classification has been done by French team, Mathieu Tonin and Bertrand Sodecote. They work a lot on this topic, and this describe different lesion of the different rump lesion until from type 1 to type 5, and you can read that on their paper. And they propose a sort of systematic evaluation during the surgery, and I must admit that I do that regularly now as well. So when you do any ACL reconstruction, as your the percentage of negative, I mean the percentage of misdiagnosis with the X-ray and the MRI, with the clinical MRI, sorry, are important and are possible. So we need to have a high level of suspicion. So for that reason, systematically, it's recommended to explore the posterior part of the medial meniscus. So you put the arthroscope in the notch. You, if it is absolutely clear, you don't have to do that, but otherwise you have to do a posterior medial portal to probe and to palpate the posterior part of the meniscus, because sometimes only with the probe you can show that there is a rump lesion. And then to do a repair, and the repair is using the technique that we use in the shoulder surgery, with direct passage of the suture, with usually a shuttle relay system with a hook that the shoulder surgeon knows very well. So we do this kind of thing. This is the right knee. You pass through the posterior medial portal, you pass the hook, and then you pass a suture. Some people pass a PDS. I prefer to use a non-absorbable suture to be stronger, because we have the experience with shoulder that PDS has been abandoned. And this is a kind of technique. This is one of the examples that I can show you. This is a right knee. You see this lesion is quite significant. So you go in the posterior medial. Sometimes some people propose to use a 70-degree arthroscope, because sometimes with a 30-degree, it's not so easy. And sometimes it's difficult to reach this posterior medial part of the knee. You clean up, you explore. This one is probably a type 4, type 5, maybe of the rump lesion. And then when you repair, you have to reconstruct and to reduce the meniscus to get a healing process. What about the postoperative management? It's quite controversial. Do we need a brace? Do we need weight bearing and not weight bearing? Flexion more than 90 degrees? How long time? Actually, there is no consensus, but for the rump lesion, I put the patient in the weight bearing, because I believe that the condyle will push the meniscus in the good way for the healing process, like any peripheral, because actually rump lesion is nothing else than the longitudinal vertical lesion, but in the synovial, in the capsule. But I limit restrict the flexion of the patient at 90 degrees during the first 4 weeks to avoid to push on the capsule, and to sometimes they can pull on the semimembranosis, and we know with some recent studies that the subimum meniscus can pull on the capsule and put in danger the suture. Now the roots is another topic that has been highlighted by different teams recently, and this is important to understand because probably we underestimated. I underestimated a few years ago myself, and I'm sure I'm not the only one. And the roots are a strong anchorage of the meniscus, and they are a specific role because they convert and disperse the axial tibiofemoral loads between the femur and the tibia as hoop stresses, and 50% to 70% of the medial and lateral compartment loads are absorbed by the meniscus through this root. So if the root doesn't work, it means there is a deficiency of the meniscus, and during a root tear, what is the biomechanical effect? There is a failure of the meniscus to convert axial loads in these hoop stresses. And Haller and Al, a few years ago already, showed that the peak contact pressure after a medial meniscus root tear could be considered as a total medial total meniscectomy. So if there is an extrusion of the medial meniscus, as you can see on this draw, it means the meniscus is not anymore between the femur and the tibia, and we can consider it almost equivalent of a non-functional meniscus. So these lesions were probably underestimated, need to be explored cautiously. And we talk essentially about the posterior roots and not the anterior roots, which is another topic. By definition, and Pagnani described that in 1991 for the first time, he cornered the term of root tear. There are radial tears, or radial tears, within 1 centimeter of the meniscus root insertion, or an avulsion of the insertion of the meniscus, of course. Their prevalence is between 7% to 9%, so less frequent than the rump lesion during ACL reconstruction, but it's quite significant because almost 10% of the case are root tear. What about the epidemiology? We need to understand that there are 2 different types of meniscus root tear, 2 different contexts. Even if it is a little bit schematic, the lateral meniscus, posterior lateral meniscus root tear is usually concomitant to ACL tear or even multiligament injury in an acute setting in young population. Controversy, the medial posterior root tear is more in the context of degenerative lesion, chronic, and more happening more in the senior population. Again, always classification. Laprade proposed this classification of the root tear, and Forkel and Peterson complete that for the lateral meniscus based on the lesion or not of the meniscofemoral ligament, which is important for the lateral meniscus. The symptoms are not really specific. It can be posterior knee pain, pain in full knee flexion, McMurray positive, popping sound, and usually the classical catching, locking, and giving way seem to be less common for the root tears. And again, think about the 2 different contexts. Context of ACL injury, lateral meniscus, context of degenerative medial meniscus. And there is one typical group of risk factor which must lead to a high degree of clinical suspicion is older age, female sex, increased body mass index with various myeloma, and increased Kellgren-Lawrence grade. And if you see this kind of patient, which is very frequent, there is you will see that you will notice that they have some medial meniscus, posterior meniscus tear. What about the imaging? 3 typical imaging signs: the meniscus extrusion on coronal, the high signal on the axial, and the ghost sign in sagittal. So it means you don't see anymore the posterior part of the medial meniscus on the sagittal view. This is good, but this is good mostly for the medial meniscus. For the lateral meniscus, it's less clear. And as for the lateral meniscus, it happens usually during an ACL reconstruction. There is clearly recommendation to explore the root. So now it's not easy like 20 years ago. You have to explore everything. You have to go to explore the rump lesion and the rump of the posterior medial meniscus. You have to palpate the 2 posterior meniscus root, and you should do that each time you do an ACL reconstruction. Sometimes it's less obvious, like in this case, you know, and only when I used the grasper to move the posterior part of the medial meniscus, I could see that he had a posterior meniscus root, which are only suspected on the pre-op imaging, but not obvious in the, like in the complete rupture. What is the treatment? The non-operative treatment is still okay with the elderly context of advanced osteoarthritis. Meniscectomy could be partial tear in case of partial tear when there is an osteoarthritis with shocking episode. So I don't think we need to discuss. Maybe we will have to repair in the future, but for the moment, I don't think to repair in the context of advanced osteoarthritis can bring something, but something to be discussed in the future. But for young patients with healthy knee, clearly we need to repair. And but in the same time, we should consider the BMI and the malalignment. You need to know the exact anatomy, and I recommend you to read the reference paper for that. I don't have time to go into detail, but it's important to know which are the anatomy. It can be a direct repair. It's not frequent, but this is an example I did at one time because the lesion was quite far, if I say, from the root. So you can still use this kind of a direct repair. You can use anchors from the medial meniscus with a posterior medial approach, but in general, now the recommendation is to use tibial tunnel. We pass through the tunnel until the root, and we use a different low profile instrument with, for the medial meniscus, it's quite frequently easy and helpful to use the pie crusting technique because the medial compartment is sometimes very tight, which is not the case for the lateral meniscus. You can use suture, you can use tape. This is one of the cases it is with only one tunnel. Each case is different. So you can do two tunnel, you can do two suture, but in this case, you know, it was a sort of oblique lesion. So I passed the suture inside the posterior part of the meniscus with a non-absorbable suture. So you retrieve the suture through the tibial tunnel, and you will fix the meniscus root, the posterior medial meniscus root with this suture. But as it was an oblique lesion, I like to do in this case, in addition to the suture, the transtibial repair, a vertical all inside suture to fix on the posterior part of the capsule. So, what is the postoperative management? It's quite controversial, but remember that if you put the weight, it will push on the lateral or medial meniscus, and it will push on your suture. So it makes sense for me, even if there is no controversial, that to propose non-weight bearing between 4 to 6 weeks, flexion limited to 90 degrees for the same reason, leg press and squat limited initially, and return to sport usually after 6 months. So is there any evidence on the root tears? Yes, we start to have some evidence. The natural history of meniscus root tears is particularly poor. So we have some osteoarthritis if we don't do repair. The repair of the medial meniscus root tear in the literature show that there is less osteoarthritis than we do a total meniscectomy. Clinical results are quite good in good indication, young patient and acute or non-chronic lesion in more than 95% of the patient, but the high BMI should bring your attention because the results are less good when there is a high BMI in this kind of patient. And finally, to finish this presentation, we'd like just to give a few words about the repair enhancement, biological augmentation. We have a lot of paper, a lot of excitation, a lot of discussion about that. And I will recommend you to read this recent paper published in JISACOS in 2020, this year, state-of-the-art done by some surgeons who have big experience in this field. And it's interesting to see that we have a lot of technique, meniscus abrasion using a rasp, so the simple one, through the scaffold and with the trephination, fibrin cuts, you know, bone marrow stimulation, which is maximum when we do ACL reconstruction during the same time PRP stem cell therapy. So a lot of hope, but actually the conclusion of the paper is that the literature on each method of biological augmentation has some heterogeneity, difficult to compare, challenging. So currently they conclude to say that no biological method has demonstrated a clear efficacy and or superiority over meniscus repair alone in clinical trials. So in conclusion, I would say, do your meniscus repair, save the meniscus. Don't hope too much in biological augmentation, even if we don't have to extremely something. Try to do the best technique to have a stable meniscus repair after a good debridement. And this is how you can help the most your patient, in my opinion. Thank you.
Thank you very much, Philippe, for this very nice presentation. So we'll move on with Dr. Brian Kuhl for the next presentation on meniscal allograft. As we briefly mentioned before, Dr. Brian Kuhl, he is an orthopedic and sports medicine surgeon at Midwest Orthopaedic at Rush University. He's the professor of orthopedic and associate chairman of the Department of Orthopedic at Rush University Medical Center in Chicago. Welcome, Dr. Kuhl.
Thank you, and thank you for having me this evening. I realize we have a big time difference. So what I'd like to do is share with you I'm 25 years in practice, almost, and I want to share with you some thoughts and our indications and outcomes and so forth, and look at some of the independent variables that we've looked at over time to either assure success or prevent failure after a meniscal transplant. My disclosures are at the Academy Orthopedic Surgeons website. It's interesting that there's about 500 to 750,000 meniscectomies performed per year, but when you look at least in the United States, there's only about 1,500 to 2,000 meniscal allografts performed per year. So it speaks to the fact that most people who undergo a meniscectomy do fine, or they present later in life with sufficiently advanced disease that they're too late for a meniscal allograft. In other words, they have this brewing osteoarthritis that over time that doesn't present with symptoms till it's too late, which is also not uncommon type of presentation. We've performed probably nearly 700,000 meniscal transplants, 700 meniscal transplants in the last 23 years. And what's interesting is that when I look at how many of my own patients who I did a meniscectomy on who ultimately came from meniscal transplant, that's only really about 10 patients. The indications obviously include a mechanically absent meniscus. They don't have to have a completely absent meniscus, but an area that's sufficiently missing that can otherwise lead to increased contact forces across the joint, resulting in symptoms. Another indication is instability, which I think that's an evolving indication, whether or not the posterior horn of the medial meniscus, for example, serves as a secondary stabilizer, as you just heard, with ACL deficiency. That's been a limited indication for me in terms of revision ACL reconstruction, largely in the area when an ACL has been reconstructed and it gets progressively loose over time in a meniscectomized state. No matter what we do, the ACL reconstruction is really what has to take priority. So it can be a difficult operation. They can both be done simultaneously, but you would never want to compromise a revision ACL while you're trying to dodge tunnels and slots and so forth from meniscal transplant. Just like any cartilage procedure, it's important to address comorbidities. The most common one is a secondary cartilage problem that results after a meniscectomy. And there are some subtle differences in terms of how these present. When there's flattening or tibial-femoral subluxation, those would clearly be more relative contraindications. Anything that's a high-grade lesion can now be managed with a cartilage repair procedure, and we typically do these at the time of reconstruction, most commonly with either cell-based technology or an osteochondral allograft. In fact, my #1 transplant procedure now is a meniscal transplant with an osteochondral allograft that's fresh. The other comorbidity that commonly is in consideration is malalignment. So I'd say #1 comorbidity is a concomitant cartilage defect. #2 is malalignment. And it's not uncommon that we're dealing with that triad with meniscal deficiency, malalignment, and articular cartilage defects. There is a lot of discussion that evolves around should we be doing these very early. There's a few studies that have looked at early versus delayed, and my personal opinion, and this is a letter to the editor in response to this article by Dr. Yang from China, that we are really not knowledgeable enough about the natural history of the meniscectomized knees to say that we should do this in for preventative reasons in the asymptomatic, recently meniscectomized patients. The principal reason for that opinion is that this meniscal transplant will not last forever. Cartilage progression without the meniscus is not predictable, and nor do we conclusively know that there's chondroprotection with a meniscal transplant. And when you put a meniscus in a patient who you'd otherwise allow to go back to sports, they now live a life of relative meniscal protection. So you're putting something in there that would otherwise potentially be damaged when they return to sport. These are all reasons, and there's several others, why I would not advocate for meniscal transplantation in the asymptomatic meniscectomized knee. Radiographs are important. On the left is the same patient as the one on the right, and that's an extension view. If you focus on the knee on the right, which is the patient's left knee, the knee on the right on the x-ray in extension is a very different view when that patient flexes their knee to a PA view, or the so-called tunnel view, which indicates, in fact, that that patient has bone-on-bone arthritis, would be contraindicated. You get a much more better idea when you, at the time of arthroscopy, and if you could advance again, you'll see in this patient at arthroscopy, you would never expect this much damage. It eburnated bone in the femur and the tibia, and this is really a bipolar arthritic knee, but it's underappreciated with an x-ray that was taken in extension. So you can learn a lot even without an MRI just by the proper x-ray. We also will get alignment views to assess for malalignment when clinically they look like they're malaligned. Just advance a couple of clicks here. This is the method that I currently use. It was published in 1995. It's an old method, but it continues to work extremely well. We essentially put a magnification marker on the x-ray. You can use a 1/4 or a 100 millimeter marker. And in the AP view, this A view on the medial lateral side, there's a 1-to-1 ratio. If you draw a line along the tibial eminence and then the periphery of the tibia, you get a sense of what the meniscus width is in the AP view. And you just correct for magnification. There's typically about a 5 to 8% magnification when you take a routine x-ray. So you can take the measure between those two lines and then reduce it by the amount of magnification that's on the x-ray. When the tissue bank gets the meniscus, they actually will match that number as closely as possible to the measurements taken from plain x-rays. Similarly, on the lateral view, because the anterior posterior horns are closer together, we reduce it for the medial meniscus by about 20%. And for the lateral meniscus, reduce it by about 30%. What happens if you over or undersize the meniscus? It is sometimes very difficult to get the proper size meniscus. And what we've generally learned is that you want to be as close as possible. If you're going to be off, I'd rather be a little big than a little small. And what we've learned biomechanically from this and other studies by Bob Burks is that up to a 10% size mismatch might be acceptable to approximate the meniscal femoral, tibial femoral contact forces. There is some discussion about surgical technique, whether or not you should indeed keep the bone insertion. I would argue that that time equals 0 is not the same thing as what happens over time. So what happens is that if you look at time equals 0, you would argue that you should definitely include bone. But what happens is as the meniscal heals into a bone tunnel, if you don't use bone, is it maybe the same thing as leaving bone intact. So there are a couple European investigators, clinicians that have, like the Verdonks, who will use soft tissue only, for example, who have a large experience, and their experience mirrors ours where we actually continue to use bone. I like bone because it's efficient. This is one of the original techniques of using bone plugs, as you see here. It can be done into a blind tunnel through a transosseous repair. The challenge is that if you're doing an ACL reconstruction, the tunnels can be very difficult to avoid. And if you're doing an osteotomy, it can be impossible to avoid these if you do a high tibial osteotomy. The other technique is a slot technique. There are a couple of companies that have different types of slot instrumentation. The one that we like to use is the meniscal slot technique that Jack Farr and I developed. There are 3 companies that make this instrumentation. It's very simple. You can prepare this while the patient is being draped and prepped, assuming you have good information about what you're getting into. But basically, it's a 1 centimeter deep, 8 millimeter wide slot that is a rectangle that slides in very easily and can be fixed with a suture anchor on the far side of it to push it into the involved compartment. It's a very easy, reproducible technique. It prevents the graft from being hung up as you're introducing it into the knee. And we'll always cut off the bone along the back of the meniscus, along the posterior horn. So that you don't get stuck with the meniscus sitting too far forward. So while we'll cut the bone off at the back of the meniscus, we'll keep it in the front. And then we use an interference screw or something equivalent adjacent to the bone block on the far side of it to push into the compartment. The reason I like this technique is it allows us to do concomitant ACL reconstructions and osteotomies, and we're not dodging tunnels at the same time. And we know from our biomechanical work that it reapproximates tibial femoral forces, and you can do this on the medial and lateral side. So for me, in my hands, for hundreds of meniscal transplants, this has been a very easy, minimal resources required, doesn't need any fancy jigs. It's just a saw and a ruler, quite frankly, and it's extremely fast and efficient. On the top left is basically the meniscectomized knee. We like to leave a little peripheral meniscal capsule, not too much meniscus remaining. We then create a provisional slot, as you see in the top right. That's the depth of a burr or a bone cutter, so that's about 4 millimeters in depth. We then place a outrigger or a depth gauge from outside inside the knee that goes in that slot, lays in the slot, and then we just advance a guide pin a couple millimeters below that. We then ream a 7 millimeter reamer from anterior to posterior. You can do it by feel or use fluoroscopy. We then use a box cutter, as seen in the top left, to excise bone. On the top right, you see a 3-sided meniscal rasp that just turns that slot into a nice clean rectangle. We always use an inside-out meniscal repair. I will not use all inside devices entirely. I'll use them in the back, but they're expensive and a little bit less reliable than standard sutures that are vertical matchers, non-absorbable sutures is my suture of choice. That bottom right picture is a Achilles allograft for a ACL reconstruction being done at the same time as a meniscal allograft. I'll tell you that probably the hardest operation is doing a concomitant meniscal transplant with an ACL, but using the slot technique we've learned it has become quite reproducible. That's the meniscus going in the front. It's very easy to introduce. You just basically just push it in, put the knee in varus or valgus, depending on whether you're doing a medial or lateral meniscus, and you basically insert it into the knee, placing an interference screw along the far side of the graft, and then we use vertical matcher sutures to repair it. So what can we do? What can we tell our patients? What do they find that's clinically relevant in terms of change, in terms of reducing pain and improving function? There are a number of studies that have been done that you see here. And then there's a number of studies that have been done that have provided systematic reviews. And rather than go through all these papers, I'll highlight just what the results of these suggest. When you look at the Lysholm score at final follow-up, they generally range between 80 and 85 on a 100-point scale. When we look at the Tegner score at final follow-up, we generally see about a 5. And some of these are some strange activities that are done in different countries, but the Tegner score it ranges between 0 and 10, and it speaks to the variability of these patients, but we average on a 5 overall. When we look at the IKDC at final follow-up, we get an IKDC in-go of about 50, but they have out-go at post-op follow-up at various timeframes of about 70. Satisfaction rate uniformly has been quite good, and it's been in excess of 80% in most studies that have looked at satisfaction. I think the return to sport is one of the more interesting things. We've looked a lot at our patients to return to sport, and I'll tell you that what I tell my patients is that, look, putting a meniscus in is if we need that to reduce your pain so you can be more active, we got to do what we got to do to get you better. But I've been very surprised at how few have come back, even when going back to cutting and pivoting sports. I cannot conclusively say that return to sport leads to early compromise of the tissue, but intuitively know that a meniscal transplant will never be as good as what we started with. So I do caution patients that if all things were equal and there's 2 things that they like doing, choose the sport that is less meniscal dependent to preserve the life of that meniscus, knowing that it's not going to last forever. We've looked at adolescents, and the good thing about this technique, the bridge and slot technique, is that it's physeal sparing. So we have looked at patients with open growth plates, as you see here, and we do just as well. Keep in mind that reoperation rates for all cartilage procedures ranges between 20 and 35%. So you can't get too discouraged when it comes to the need for reoperation. The complication rates are relatively low. I would say the #1 complication rate is actually the failure to alleviate pain, and that's not reported in studies looking at constant complications in general. But I would say that the anatomic complication rate includes tearing of the allograft over time. I think you should think of this as basically a stent that's placed that is going to last 7 to 10 years. So it speaks to the fact, why would you do prophylactic meniscal transplants when the onset of arthritis can be 15, 20 years? It can be 20 to 25 years before that actually becomes symptomatic. And without concrete evidence that this is a chondroprotective procedure, doing prophylactic meniscal transplants, in my mind, is counterintuitive because it just doesn't last forever. When you look at long-term follow-up, or I would say intermediate to long-term follow-up at 7 years, we basically are finding satisfaction rates which are very high with success rates that exceed 85%. We've also looked at our failures, and I think failure is important to look at. A lot of our procedures, as I mentioned, are combined. We've had a 95% survival, a 32% reoperation rate at a mean of 21 months. So just be prepared for that. Educate your patients that that's a problem. What's interesting is that about 60% of them are debrided, and about 2/3 of them feel better with a debridement with a second look arthroscopy. The one thing I will say, though, is that the odds ratio to go on to knee replacement is exponentially increased if they do require a second surgery over time. So that's one thing we've learned, is that if you got to go back, you can make them better, but the likelihood is that they will be a high-risk category going on to osteoarthritis in the future that might require further treatment, such as arthroplasty. Just getting a sense, just to give you a snapshot of how these things do over time, when you look at the articles that are there, you can see that meniscal transplants over time, the success rates and the persistence rates are about 50% when you get to 10 years. So they don't last forever, which is, again, supports my contention that prophylaxis is probably not a good idea necessarily, given they outstrip the timeline required for disease to develop. But, you know, look, we do very well for an area that has otherwise not had a good solution. Go back. With respect to revision, we've also looked at if you can revise these, and yes, you can. You got to make sure that you take care of the comorbidities that may have developed over time. But I'm going to tell you that our satisfaction rates are as good with revision as they are with primary. So as long as you correct the comorbidities, if the tissue fails, you can do it again. This is, given the number of patients we have, I've started to break it down into different independent variables to talk about, what is the status of bone marrow lesions and its effect on outcome. And what is interesting is that when the bone marrow lesion size is inversely related to the clinical outcome. So the more bone marrow they have shows that they've been overloaded for some time. I would urge you not to think of bone marrow as signals as a lesion. It's just really a sign of overload, and you see it in osteoarthritis. So I would suggest to you that when they have lots of bone marrow edema, they're really looking and feeling physiologically like osteoarthritis, and it's possible that the horse is out of the barn, if you will, in terms of our ability to render them less symptomatic. So we don't do as well when they have lots and lots of bone marrow edema. I also wanted to know that what the relevance of the tibia was, because we do have patients with bipolar disease. So we looked very carefully separating out patients who had femoral disease, tibial disease, bipolar disease. And what's interesting is that what we found is that patients actually tolerate tibial disease more than femoral disease. Said as another way, that if you have a patient who has bipolar disease where the femur dominates and you treat the femur responsibly, do the meniscal transplant, a little bit of tibial disease doesn't seem to compromise the outcome. We don't have great solutions for the tibia, so we're lucky that the tibia doesn't have as dramatic of as an impact. So this is something that I can counsel my patients on, and it helps us understand when we can actually push the envelope to doing these procedures. This is really the pivotal question that everyone wants to have answered, and is there evidence to show that meniscal transplants are chondroprotective? And I would argue that we don't have a litany of evidence that shows us this, but Tim Spalding has done the most in this area. I commend him for his prospective research looking at the relevance of meniscal extrusion. That what's fascinating is when we see meniscal extrusion, much like you see with a root tear, it doesn't seem to be associated with inferior outcomes. And in addition, we're also finding that the ability to chondroprotect still remains questionable, but Tim Spalding is actually finding some emerging data that suggests that maybe what we're doing could be chondroprotective. But you have to ask yourself about the age that the meniscectomy happens, the fact that these patients often do extremely well for decades, and this meniscal transplant will ultimately fail often before they become symptomatic. So it becomes a very challenging discussion to have with your patients who can do very well in the near intermediate term with a meniscectomy. Not long ago, we published the International Meniscus Reconstruction Experts Forum. This is a consensus statement amongst many of us who do lots of meniscal transplants, and I'll share with you our findings. We all were able to agree that the indications were pain in the presence of a functional meniscectomy, doing a meniscal allograft as a concomitant procedure to revision ACL or to articular cartilage repair. We agreed that it would not be a procedure that should routinely be performed in the asymptomatic patient. We demonstrated that the group felt we should have great caution if we had advanced arthritic change, certainly if it's not corrected. Non-irradiated frozen or viable meniscal allografts are both okay. The industry standard seems to be frozen grafts, not cryopreserved. Certainly we all use some type of quantitative methods. I have used x-rays for decades and still have no problem using x-rays, but MRI can be a useful tool. There seems to be no superiority of one technique over the other, which includes with or without bone, a trough, a dovetail, or bone plugs. I would say that the tendency is to use some type of bony procedure on the lateral side and bone plugs on the medial side. I use bone blocks on both sides. There's a very low threshold to do an osteotomy when there's any mechanical axis deviation. And there seems to be an abundance of caution in returning people back to sport. Although I will tell you, as I've already said, that we've had great success in even returning collision athletes back to sport. So in conclusion, like anything we do, especially in an area that is emerging in terms of our understanding of outcomes, proper indications are critical. We know that earlier is better, but too early may not be warranted. We see patients reliably achieve an MCID with multiple patient-reported outcomes. There's a very high satisfaction rate following meniscal transplantation. We have learned that we can get our athletes back to play about 2/3 of the time, and that response is somewhat sustainable. We have seen survivorship, a minimum of 50% at 10 years, and we've seen a very low complication rate overall. So we think in general that a meniscal allograft will make a patient more age appropriate for arthroplasty, but we've also learned recently that patients who undergo meniscal transplant do not fare as well if they go to arthroplasty. So in general, cartilage patients who are treated by us, when they require arthroplasty, they seem to be a more challenging group overall to get rid of their pain and get a satisfactory outcome. So anyway, that's what I've got for you this evening. I wish you all safety and wellness. And
thank you very much, Professor Kuhl, for this nice presentation.